This is an effort. Srijan and I started a couple years ago to do essentially platform recruitment for people coming in for treatment to the outpatient psychiatry clinics at U of M, as well as some other clinics associated with the health system. So our initial funding came from the U of M Precision Health Initiative. It's called alternately PROMPT, or the opioid use, not the opioid use case, the mental health use case on their website. We recently received an R01 from NIMH to do an observational study building off of this recruitment platform. But I'm going to, primarily focus on the work we've done under the Precision Health Initiative funding, which included randomization and testing of different interventions. And I have some preliminary results to share from those mobile app interventions. This is the background premise to why we started the PROMPT study. It was thinking about the challenges with how mental health care is delivered writ large in the country at this point, and how digital health could help improve that care in multiple dimensions. And this was adapted from a perspective piece written by Tom Insel, the former director of NIMH. In summary, what was true in 2018, 19, when we first conceived of this study, and unfortunately what is still true today, is that by and large, treatment is episodic. People get clinic-based treatment, or they're not in the clinic, and there's long wait times to get that care. It's very effortful to deliver that care because it requires so much person time, and there's just not enough clinicians. It's also subjective, so we don't objectively measure how people are functioning. We ask them to recall their symptoms over long periods of time. And there's very little matching of what treatment people get to what their specific, anything about them specifically. It tends to just be, we try something, if it doesn't work, we escalate and add more things. What we think should be done instead is that it should be objective. And I have some data getting at that idea of being able to measure when people are experiencing recovery. There should be continuous measurement of how people are done, not just, let me ask you about the last 6 months at your intake. It should be ubiquitous. People should have access to care, at least through mobile apps immediately. And ideally, this all builds to a model where people get the right treatment with the first treatment they try that's most likely to be successful for them, because we know how to match people to treatment, which will reduce burden on the entire system because people will get better faster. In terms of what that means for PROMPT and how we designed this study, we had 2 goals. One was to increase treatment capacity at outpatient psychiatry through adding more mobile health interventions available to people as they start to get scheduled. And then accelerating recovery by matching treatment to patient being our long-term goal once we are able to learn from the data we collect. So as I mentioned, the primary site has been outpatient psychiatry. We've worked a little bit with UHS and also with the collaborative care clinics in primary care. We recruit people, at the point at which they are have their first visit scheduled. So typically that means people have been waiting for care for a number of months. They've been on a wait list. They're scheduled about 8 to 10 weeks out. We try and catch them at least 2 weeks prior to their first appointment so that we can get them randomized, get some mobile apps to them. Usually people have at least 6 weeks before their first appointment by the time they've done their baseline. And the reason why we didn't go further back into the wait list is, some people don't convert to becoming patients. They're on the wait list and get care elsewhere. So we wanted to wait to the point where people still have as long as possible before they start in-clinic visits, so we can see how mobile interventions help them, but know that they will eventually become U of M patients. Because we are both looking at that pre-clinic visit point where we can look at mobile interventions, which is mostly what I'll talk about today. But ultimately in the R01 phase of this work, we're going to look more at what they get in clinic in terms of types of therapy, types of medications, and build towards matching treatment to, sorry, I got distracted by the chat, all the entries, matching treatment to individuals so that they can start the first thing that's going to be most effective for them. In terms of what this looks like from a subject point of view, so we recruit people while they're waiting for care. Ideally, our process works where there's a warm handoff from the person who is scheduling their visit for the clinic to the prompt staff. That happens sometimes, but we also send people emails or follow up with them by phone to get them enrolled in the study. They onboard through the mobile app. So we use the CareEvolution My Data Helps app for this project, and we send them a Fitbit in the mail, and then they complete follow-up surveys at multiple different time points. And we typically expect that week 6 survey happens around the time that they're starting to have their first clinic visit. So it provides kind of a pre-clinic baseline in addition to the baseline, which is our pre-mobile intervention baseline, which I will talk about what those mobile interventions are. So we use a Fitbit for this study, so everybody gets sent a Fitbit. There are some people who have an Apple Watch already who choose to use that for their study wearable. We have 2 types of off-the-shelf app interventions we've used in the precision health portion of the study. So we use Headspace as a example of a typical mindfulness app, and then we use SilverCloud as an example of a CBT app. Both we selected with having some good prior studies in the literature showing benefit to their apps. And for both, well, for SilverCloud, there is a clear depression and anxiety track. For Headspace, we came up with some recommended meditations to do based on whether someone has higher depression or anxiety symptoms. So with both of these, there are also tracks based on that proportion of the degree to which anxiety or depression is more predominant for them. We then also have a study app. So this is built off of the My Data Helps app, where there is a participant-facing dashboard that takes in information on their sleep and steps from their wearable, and then how many minutes they used their assigned app, whether that's Headspace or SilverCloud, coming from the apps on the phone, talking to one another, so to speak, and provides summary information to help people do self-management through reflecting on how their sleep and their steps may affect their mood, because we also assess people with daily mood scores. The intervention also has daily notifications that are tailored based on someone's information from the wearable, which you can see the example here is from the intern study because we based that off of the intern study intervention. In terms of our randomization scheme, you could think of this as either a 5-group design or a 3-group design with secondary randomization in 2 of the groups. One group gets the SF here stands for standard feedback, so just the information that someone's Apple Watch or Fitbit gives them on their sleep and steps. One group that is a third of the sample gets the study app, which we're calling an enhanced feedback here. One group gets either Headspace or SilverCloud, and that's where that secondary randomization is. They get randomized to one or the other. And then one group gets both of those things, the study app plus the Headspace or SilverCloud, again with that secondary randomization. And in theory, as we conceptualized it, although I don't know if this is totally played out, the study app should help increase the efficacy of the CBT or mindfulness app by increasing use. This is just a little bit of data on our enrollment. So you can see we've had fairly steady enrollment over time. We started during the pandemic, so we had not been planning for this to be a fully remote study, but it has worked reasonably well that way, and we've continued that way. So we have over 2,000 participants. This is as of last Monday. If people have worked with CareEvolution, this kind of receiving a report on your recruitment may look familiar. The sample is about 70% female, as you'd expect with this being outpatient psychiatry patients, and about 2/3 are iPhone users and 1/3 Android users. With this sample size, I didn't say that but should have said that the prompt data is meant to be available for everyone, not just Srijan and I and our direct collaborators. So with a sample of this size, there's lots of subgroups. I mean, there's lots of questions that could and should be answered at the entire sample level, but also people have interest in specific patient subgroups. Our goal is for this to be large enough to be able to provide pilot data or just outright opportunities to write papers on, I know Sarah Sperry has been looking into it and that there's enough people with bipolar disorder in the sample to do some interesting papers on that. Lots of opportunities like that, although these are all adults. So unfortunately, at this point, not able to do questions around child and adolescent mental health. Our engagement in the study has been higher than I even expected. This has been a nice surprise. We had 92% completion of the 6-week survey, but this second one was, for a lot of studies, both Srijan and I have done with daily assessment before, it's more typical to get about half of subject days having completed their daily assessment. And in this study, when we look at the first 6 weeks, we get about 83% completion. We also have decent use of the Headspace and SilverCloud apps, and I'll show some more data that Elizabeth recently looked at with that in a second. The second is now. So this is just some recent preliminary data to give you some sense of what app use looks like in this sample. With the 2,000 participants and those randomized to use Headspace or SilverCloud, there's a little over 41,000 instances of episodes of use of the apps across our subjects. What Elizabeth was having us look at here was the extreme values and thinking about outliers and just making some decisions about it. But you can see, as you'd expect, a lot of the use is clustered down around the couple minutes to 30-minute mark, which for meditations makes a lot of sense. We think we do see some people who are falling asleep to apps at night and are looking and thinking about how to handle that in analysis and what that might mean. We've also looked at the effect on symptoms just for this as an entire cohort of subjects. Since all of them are getting apps, we can kind of take a group before and after look at what happens. And with this sample, because people have been on the wait list for at least a couple of months, sometimes upwards of 10 months at the point at which they're scheduled for their appointment, we don't expect there to be a lot of regression to the mean in the first 6 months that, oftentimes people call to make an appointment when they're feeling their worst, right? And by the time they get in, they've had some improvement, but I wouldn't necessarily expect a lot of that in that last 6 weeks leading up to the appointment. So it's encouraging to see what we see here, which is that in the overall sample as a whole, all three of the measures we looked at here, PHQ for depression, GAD for anxiety, and ASSIST for substance use disorder, have significant declines in that period where they're getting apps, but still waiting for care. So encouraging on this as an approach to help bridge that waitlist period to get people some relief from their symptoms. The other thing we're starting to look at and think about doing, and is the focus of the R01 phase of this, is being able to use passive measurement of identifying who's getting better. So how to use the Fitbit data in particular, but all of the phone-based and sensor, wearable sensor data to predict who's getting better and being able to identify it more quickly, not waiting till their next clinic visit or a couple clinic visits before you can tell that someone's having some success with their treatment. So this is data, again, from that first 6-week period. This was a very simple look, but it was preliminary data for our R01. We took people who had depression with PHQ scores above 10 at their baseline assessment. We looked in that first 6 weeks, and the outcome here was who achieved remission or a PHQ below 10 at the 6-week visit, and the degree to which their change in physical activity level measured as steps, average steps per day, predicted remission. And what you can see here is a signal that is true, that for people who had more greater increases, and basically we took a median split here, greater increases in their amount of physical activity was predictive of achieving remission at the 6-month mark. So this is definitely far from being a full model. There's lots of other variables and information we could pull in here to develop. Our goal is to develop an algorithm for identifying remission early. But I think this is an encouraging signal that physical activity and some of the other measures we have may be able to do this in a longitudinal time varying way. The other goal of our R01 is to get at this matching patients to treatment. And as I mentioned, with the R01, we're going to be looking at it with in-clinic visits, but with the precision health phase of the study, we've been looking at it some with their digital interventions, the CBT, so the Silver Cloud, or mindfulness is Headspace. And so what we did for this analysis is we took people's baseline period, so the first 2 weeks after they did the baseline, we measured their steps and their sleep, and we categorized them into groups based on those 2 factors. And then we looked for people who got the CBT versus the mindfulness, how likely were they to achieve remission? And again, this is people with depression at baseline, remission defined as having a PHQ below 10 at the 6-week visit. What we found is that for most of the groups, either one of the 2 mobile intervention options looks like they were reasonably effective and pretty equal to one another. But for people who were both not very active and not sleeping very much at baseline, there was actually a pretty big difference between the 2, where they were much more likely to benefit from getting mindfulness in that period than getting CBT. So again, this is not by any means a definitive study of, here's a new matching algorithm to roll out, but I think an encouraging sign that these data can be used to match patients to treatment and make treatment decisions that should maximize their outcomes. And I will stop sharing, but I can back things up if people have questions about particular slides, but I look forward to the discussion.
Thank you so much, Amy. I see some people putting their cameras back on. Okay, go ahead with your question.
Thank you very much, Amy. A brilliant presentation. Unfortunately, I will need to log off at 1, but how successful are you at getting this into the clinics? In other words, so we have a patient that comes into the clinic. We would like to get this data and have it available to the resident, let's say the week or the whatever number of days prior to them seeing them, so that the treatment team has this trajectory before them as they're evaluating the patient. And then it might be kind of interest to see, in fact, how useful is that in the context of the various different outcome measures subsequent to this, and not talking, next week, 2 weeks, but really over the course of 1 to 2 years. And so, that the information and data from a very large French collaborative demonstrated that, getting really comprehensive information to the providers upfront really had an impact 2 and 3 years down the road. So it's not the short-term benefit, but how do we appreciate and evaluate the longer-term benefits of this?
That's a great question, Melvin. We, in the context of the funding we've had from Precision Health, we haven't been able to do that, but it's a great idea for next step. I know Kathy was interested in doing this specifically with the sleep data, of having people, come in for their first visit with that objective measurement of their sleep versus the way it works now, where they, have an intake visit where they discuss their sleep and then you do some objective measurement after the fact. We haven't been able to get funding yet specifically to add that component, which, as I'm sure you can appreciate, is not something you can easily just do on a shoestring budget, but I think it's important. And then the R01 funding is very much an observational study, so it won't have an intervention component like that. I also want to say, I think the way you're thinking about it in kind of a hybrid effectiveness implementation design, if I'm hearing it right, makes a lot of sense of like what gets clinicians to use the data, which is kind of the implementation side, and then how effective is this at improving outcomes is also really important to know.
But the data that are available to the researchers, I mean, you're getting a course of illness for a period of time. How how difficult would it be for that data to become available? I mean, do you have a dashboard or do you have some kind of way of visualizing the data and so on? How might those data become available at the level of the clinical provider?
Yeah, at this point, we get we don't have a dashboard. We get the raw data from Care Evolution and are processing it some, but not in a format that would make it easy to just put in front of a clinician yet.
Okay, thank you.
Kathy, I saw you came off or on camera. Did you have thoughts on that?
Yeah, no, I totally agree with Melvin. So like, this is like the final link is this integration piece, which it seems like, particularly for us in sleep, it seems so easy. Like, oh my gosh, I can't believe we have a field where everybody's measuring their sleep on their own or would love to measure their sleep before the visit and we can't see it. And obviously it's this kind of complicated piece of the integration with the electronic health record or having the dashboard, and then kind of like who pays for it? Is it the health system? Is it because these aren't like sleep tracking isn't really a billable thing? But I know we'll get there, and especially if we could do research showing that it does improve outcomes, I think that, especially Epic will have some impetus to integrate it into the electronic health record. But yeah, totally agree with Melvin, and I hope we get there. And thank you, Amy. That was an awesome talk.
Thanks.
I had a couple questions. Hi, Amy. It's Munish Tiwari. Nice to meet you.
Nice to meet you.
I love your talk as well. It's such a great study. And, I work in oncology and, so we have different outcomes and all of that. But like so many of these questions about how do you integrate in EHR and just your whole design are just so relevant. So I appreciate the way you laid it out. I had two questions. So one question was just kind of like, again, not being in psychiatry, with this kind of study, like how much of monitoring do you have to do in terms of like if someone's having suicidal ideation, et cetera, like how do you deal with that? I imagine maybe that's just bread and butter every day, but curious how you dealt with that.
Yeah, that is a good question. We have a team. I'm trying to see if Cece's on. We have a team of, we do have some items that get at suicide risk in our surveys. We don't have anything in the interim in between, right? Like our daily mood assessment isn't really definitive in measuring suicidality. So it's really just with the surveys with the PHQ, and we use the PANSI as well for suicide risk that we have to worry about that. We have the team who works on it have a very clear protocol of when people express ideation or behavior that's at a more serious level, where they call back and work through a risk assessment with them. There have been a very small number of occasions where we've talked people through going to get emergency care because it was clear that they were at high risk at that point. But even with this, generally higher risk sample, that's been more feasible than I might have anticipated. And we're always happy to share those protocols with other teams.
Okay, no, that's great. I see what you're saying. So you basically came up with a protocol, it sounds like, based on the risk from surveys, but it's not like one of those things where, if somebody has terrible mood scores now consistently, like that's not necessarily flagging it. Is that just because that's like a research thing? It's not a validated.
Yeah, I think there's
thing.
Yeah, there's not like a validated model for measuring acute suicide risk from the measures we have at this point. I would guess that, I'm sure there have been efforts out there to do it. I would guess they do not have high enough positive predictive value that we could use it in that way at this point.
Gotcha. And then the other question I had was, and I can follow up with email later too, but I was just sort of curious if you had any cancer patients in this population, because when you were talking about sort of subset analyses, I'd definitely be interested in collaborating, on that, and maybe even talking later if you're not already doing this in the cancer population. I know you're at the VA too, right, Amy? Is that right? I just saw online, so you probably know Phoebe Sau, or do you know Phoebe?
Yes, I do. Yeah,
Yeah.
yeah. I've worked with a few of some. So that is a good question. We haven't looked at that yet, and we can. We have the linked medical records data that we would know if they're being treated for cancer at U of M.
Yeah.
I know that the from Phoebe that there's some effort to deliver mental health care in the cancer center, right? But that's still pretty like they'd probably still be more likely to be getting their mental health treatment from outpatient psychiatry.
Yeah, I think so. I mean, and Phoebe's at the VA, so I think there's a
Right.
different system there. So anyways, I'll send you and Srijan an email and we can
Yeah.
talk offline. Yeah.
Sounds
Yeah, thank
great.
you.
I see that Gabriel put a couple of questions in the chat. I don't know. Do you prefer that? Do you want me to read them, Gabriel? Oh, he's adding additional questions as well.
Here's the thing why I forget, it's right back to me.
Okay.
So I wonder if you can tell us about the mobile app that you guys are using, like what does it do besides the sign up? And this is something that could be helpful in a clinical setting in the future. Then my other question is, have you used machine learning to get any additional insights and answer more complex questions?
Yeah. So to the first question, the study app, the My Data Helps app does a couple of things. It does deliver the surveys, right? So people can sign up through it, they do their consent through it, they do their surveys through it, but we are able to deliver those tailored notifications on a, like responsive to their current data from their wearable sensor. So it's able to deliver some interventions that way. And it's also, we're also working with Care Evolution where they're helping us with getting the sensor kit data to get some of these other measures from, so basically pulling in other measures from people's iPhones on, their use time of their phone, ambient light, some of these types of things that the iPhones are now collecting. I'm trying to think what it can't do. I mean, we could have a whole, like, what does My Data Helps do, I think, conversation with a couple people on this call. I'd be curious other people's thoughts. On the machine learning side, we have not done that yet. It's in our proposal to do it in our next steps. If you're interested and have experience with that, we would definitely welcome you working in the data to do that. It's outside of my, my personal expertise as an epidemiologist. I haven't learned the machine learning techniques. So would love to collaborate with you on specific questions. And it sounds like you're particularly interested in that with suicide risk and ideation. So maybe we could follow up on that. We have a meeting once a month with people who are working in the data to talk through data issues. So everybody's on the same, has kind of shared knowledge of some of the things we've discovered as we started doing analysis, but also to give feedback on research ideas and help make it more efficient for people to do studies and papers with the data. So would love to have you at that if you're interested in working in it.
Hi, I actually have a question. That's okay if I can jump in. Amy, thank you very much for that presentation. It's it's good for me as a reminder as well of everything that's happening in the prompt study and potentially different places that we could start thinking about other interventions. So I think I put in the chat that we are still in the very early stage of playing around with the Fitbit for sleep detection. And we recently had a team member kind of test run the Fitbit. And she told us later that she actually, unfortunately, had some low back pain. And so she really was not moving around very much at all. And what we found was that the Fitbit was reporting her sleep onset about 2 hours earlier than when she was actually going to sleep, which kind of made sense because she was in bed really not moving very much. And I know Kathy Goldstein's on this session as well, and she's been an amazing help for us in sort of navigating all of this. But I guess I'm wondering if there could be an interaction between how active someone is and the accuracy of the sleep detection. And I'm not really sure if there's a solution from this apart from kind of your approach anyway, which is to generate a really large sample size. Does that make sense?
Yes. the being able to accept more noise because you
Yeah, because
yeah. So that makes a lot of sense to me as a hypothesis. I'm curious what, you'd like to think there'd be a way to, like, I think part of what you're getting at is there might be things we could measure that would be that you would know that the sleep data is going to be of lower quality, so you could at least handle it in analysis. But I'm trying to think about like what might, activity level makes a lot of sense. We actually have pain scores. We
great.
put the numeric rating scale in our surveys, so we have that as well. I would love to do some work on pain in the sample because I'm very interested in the pain depression link. But we could think about other things as well. I think it's just the like we don't have the gold standard of what they actually slept to then be able to get at the like, so what are the predictors of having error, right?
So I guess the one encouraging thing would be that the validation studies of the devices are done like with the patient in a sleep lab, like laying down. So as long as you know when they get in bed and try and sleep and when they're done trying to sleep, the sleep classifiers seem to work really well. But what people don't know is we have like no idea. We don't know if those are like adaptive algorithm classifiers, like the longer an individual, because those are only one night validation studies. So it's possible the longer an individual wears it, there is some like personalized input from their activity and their sleep. We just don't know because all the algorithms are proprietary. So I think it would be really insightful to see, but again, you don't have, a gold standard. So you kind of, with the benefit of getting all those days of objective data, but not having a gold standard, it's hard, but it'd be interesting to see if steps associate, or if you could have and almost like with these studies, we should be getting a score with the patient's report of how accurate the sleep prediction was, but then you have all the bias because people with different sleep disorders are going to underestimate their sleep based on what they have. So it's really complicated, but I do think that, like Helen and I have talked about many times now, definitely cleaning the data when the patients get in bed and wake up is probably really helpful from an accuracy standpoint.
Yeah, I think what we're planning on doing, and I say this is all preliminary because we're still working it out. But because we have come from kind of the ActorWatch world in which there was an event marker on the device, for our studies, the subjects will continue to fill in a sleep diary just as they did previously. But we're also going to set up a system where they will essentially send a text message right before they turn off the light with the intention of falling asleep, and then a similar text message in the morning. And I think we tend to meet with them weekly and kind of review everything with them. And so we're hoping at that point to start to get a feel for, okay, in which subjects we're using Fitabase, is the Fitabase export really looking quite good and really matching what is on their sleep diary and these text messages versus those in which it doesn't. I think where it gets tricky always is people can fall asleep early, then wake up and then say, oh, I forgot to fill in my sleep diary and send this message, do it then, and then go back to sleep. So you have to start asking them, did you accidentally, unintentionally fall asleep, for example, in front of TV before you got up to go to bed? So it definitely is tricky, but I think it's something that we can delve into with our more intensive, smaller sample sizes to at least start to get an initial feel for it.
Yeah.
But yeah, we are still learning, so it's great to hear all of this. And I should also call out Victoria, who's been a super help for us, as well as Kathy, in navigating all of this Fitbit stuff.
Yes, they are great. The other thing your comment makes me think about is like, we learn more as we pull in some of these measures we're not even thinking about yet that we're starting to get from SensorKit. And what makes me think about it, the idea of like, a flare of chronic pain. I was fooling around in the health app at one point and noticed that one of the measures that Apple generates, I think from my Apple Watch, is your like gait imbalance. And I could look over the last year and like very precisely identify where I had exercise related injuries. Like I was like, oh yeah, that happened then. And then 3 months ago that happened. And like, it was, pretty on the nose. So I wonder if there might be other things, other information in there that then at at the large sample level could be like, okay, here's periods where they're clearly going to be less active. And so we need to take the connection of activity as an indicator of not being asleep with a grain of salt.
Gabriel had a suggestion in the chat about, and this is dependent probably on the type of device, but sometimes there's widgets or apps that you can like customize that you just tap it and then it records a timestamp. So that might be an option for like, I'm going to sleep or I'm waking up.
Yeah, I guess something else just to throw out there, in terms of interventions for sleep, again, very early stage, but we have ordered, it's a device called THIM, THIM, and developed by the same people actually who developed the Retimer, which we use as a wearable light device. And THIM is, and I kind of forget the official name for it, but essentially it's a quick retraining, sleep retraining program with the idea that people with chronic insomnia essentially are conditioned into feeling like they can't fall asleep efficiently. And so this process has been tested in the lab where they are waking people up, allow them to fall asleep and then wake them up straight away and then allow them to fall asleep. And it retrains them and obviously builds up some sleep pressure. So eventually they are falling asleep super quickly. And this worked reasonably well in the lab. And so now they've created this THIM device to do it. So we also are waiting to receive these and play around with them. But I just throw that out there for something down the road. If you want to move beyond just apps and something that could be shipped to someone and potentially tested to see if it improves their sleep, that could be a kooky thing to look at.
Thank you. That looks cool. Thanks for sending the link, Gabe.
Yeah, I think that would be really cool to do. In the previous point, yeah, I think it'd be really interesting to flesh out. I think in the intern study, we're finding a little bit of a, like when people are getting more depressed, their subjective sleep time, their self-reported sleep time is going down much more than their objective sleep time. And in that case, I tend to believe the Fitbit more than the people because of sort of the known bias of depressed mood and how that affects recall. And so I think trying to differentiate when to believe the device and when to believe the subject will be interesting as this data comes together.
Through the Mobile Technologies Core, we do have a group called MDEN, Mobile Data Expert Network. And one of the questions that they hope to start working on is developing or sharing protocols for missing data and like what constitutes a complete data set for analysis. And so I think that question of like, what are the right protocols around the fall asleep time and not fall asleep time will probably fit into that kind of discussion. So I appreciate that being brought up here so that we can kind of add more context, because I know everyone struggles that uses these devices on trying to figure out what is a complete data set and when do we make the cutoff for including the data set in the analysis based on the fact that there are so many different data points that can come into play. Well, if we don't have any additional questions, Danielle, do you have any announcements?
Yeah, I'm gonna stop the recording.